morning, good afternoon, good evening. I'm Chris O'Connor, Principal Investigator of the Heart Failure Collaboratory, and this is Heart of the Matter podcast. And today we're very fortunate to talk about an exciting paper and project that was just released in the Journal of American College of Cardiology about the role of kidney function in heart failure, how we define it, how we look at clinical trials, and how we think about measurement and endpoints. The collaboratory is committed to working with the Academic Research Consortium on this project to improving the therapeutic process of device, drugs, and biologics. And in doing so, we're looking for how can we create the greatest value in therapeutic development by involving all stakeholders across the ecosystem. And this project in particular was extremely rewarding and fun because we had to work with our smart colleagues across the aisle, the nephrologists. And they speak a different language than us. They speak different concepts. And we charged Anu to lead this effort. And it was, wow, was it a hard effort, but it was very rewarding. But before we start, let's just go around the table and introduce ourselves. Anu?
Yeah, thanks so much, Dr. O'Connor. Anuradha Lala, heart failure, heart function cardiologist at Mount Sinai in New York, and a real pleasure to be here.
Maria Rosa.
I'm Maria Rosa Costanzo. I'm a heart failure cardiologist with a special interest in all cardiorenal issues in Chicago.
Thank you. Muthu.
Hi, everyone. Muthu Vaduganathan. I'm a cardiologist and clinical trialist at Brigham and Women's Hospital, and I'm also an associate editor at JACC and was privileged to be able to handle this paper.
Thank you, Muthu. We'll ask you more about that. Jason?
Hi, my name is Jason Feinman. I'm one of the Advanced Heart Failure and Transplant Cardiology Fellows, also at Mount Sinai Hospital.
It's going to be great to get the young physicians' input on this process. Mona Fiuzat.
Hi, everyone. I'm Mona Fiuzat. I'm a associate professor at Duke University and a clinical trialist in heart failure, and also one of the co-chairs of the Heart Failure Collaboratory.
And last but not least, Steve.
Hi, everyone. Steve Coca. I'm a nephrologist and clinical investigator at Mount Sinai in New York. Pleasure to be with you all.
Thank you. Well, this was a challenging project. And Anu, I want you to describe what was the purpose of this project and why was it so important to have the collaboration across multiple disciplines, particularly our nephrology colleagues?
Yeah, thanks so much. I mean, talk about a labor of love. We all know that changes in kidney function are so commonly encountered in heart failure across the variety of settings, whether it's in the acute setting or in the chronic setting. And generally, these changes in kidney function are denoted by changes in serum creatinine or estimated glomerular filtration rate, or eGFR. But the issue has always been that the timing at which we assess these, markers essentially of kidney function, the thresholds of significance when they change, standardization of all of those are really lacking. And that makes for a really difficult interpretation of clinical trials across settings. What is the threshold at which we say, okay, this creatinine rise is too much, this drug or this intervention is not safe, et cetera. And so, what we really sought to do here was to propose across the aisle with our nephrology colleagues and really be educated by them to propose a standardization of definitions when it comes to kidney function changes in the setting of heart failure, both acute and chronic. And I think this was honestly, I would say, one of the most important endeavors I've had the privilege of being a part of, because I think it's only when cardiology and nephrology come together that we can actually move the needle in this space. And so really the purpose here was to propose a starting point. We recognize that there may not be enough evidence to support exactly everything that we've outlined, but to propose a starting point by which clinical trials can have standardized definitions for changes in kidney function in the setting of heart failure. And then we can move forward to fill in the gaps in knowledge.
A terrific, description of this mission, and there was so much was around definitions and words and standardization and communication. And you think it took to 2025 to sort of, when you look at the body of work you put into this, and I know Jason helped tremendously here as the fellow to put all these trials together and look at the heterogeneity. And it came down to words and communication. I want to ask Muthu, as an editor, associate editor at JACC, why do words matter?
No, it's tremendously important, and JACC was very excited to partner with the Heart Failure Collaboratory on this paper and others in helping to standardize those words, especially in how we communicate as a part of a language of clinical trials. Ultimately, I think we've all been in individual rooms where we don't have such consensus. We don't have these statements available, and we often make arbitrary decisions to move the process along. And I think this paper has so nicely outlined that in both acute and chronic settings, trials have used such varied definitions for what is a meaningful change in kidney function and what is a meaningful kidney outcome. And so hopefully this paper helps to standardize that clinical trial language for use in the future.
And Steve, as a nephrologist, why did you let cardiologists get away with this laziness around terminology and word use for so long? I mean, you just let us go down the path of, almost walking the plank and then falling off into the river. Why did you do that?
Well, to be truthful, in my talks over the years and in my papers, I actually acknowledged that the cardiologists had the nomenclature more correct than the nephrologists did. And we've pointed that out essentially in the paper, that we should not use the term acute kidney injury to describe these changes in kidney function that happen in acute heart failure. And largely because there is not, while the nephrology community changed our vague definitions of acute renal failure, et cetera, to acute kidney injury. There's not necessarily kidney tubule injury occurring in these settings. It's largely hemodynamic perturbations that result in the fluctuations in kidney function. And B, I've often acknowledged that the terms that the cardiologists used in the literature when describing this as worsening renal function are more appropriate, although my favorite terminology that I'm so proud that came out as one of the recommended terms of permissive hypercreatinemia, because that worsening renal function can still be seen as a danger signal to clinicians and younger trainees, et cetera, who reflectively react to every change in creatinine as they're doing something wrong, and they have to decrease the diuresis or decongestion processes. So that permissive hypercreatinemia is that tongue-in-cheek analogy to what we have done now for years in ARDS, where we allow for permissive hypercapnia. We're using low tidal volumes to prevent barotrauma in these patients with ARDS. And here you're allowing for those changes in kidney function with permissive hypercreatinemia to occur while you're pursuing and inducing decongestion in these patients. So it's been a morass, but I think we're getting some clarity here, and I'm glad we are coming together. But again, cardiologists actually had it more correct than the nephrologists by leaving out the terms kidney injury and using this worsening.
Well, Steve, we're not going to edit that quote. That will be highlighted. So don't worry. We will highlight that. But I want to ask Maria Rosa, as somebody in health system leadership, there's a lot of pressure on physicians to code comorbidities. Heart failure is the number one cause of hospitalization over the age of 65 in health system. A lot of pressure on our health systems to get the coding right. There's all this education. Acute kidney injury gives you more reimbursement than if you say permissive hypercreatinemia. I don't even think, people know what that is or how they would code for that. Tell us why it's so important for the clinicians, and many of them are not going to be heart failure cardiologists taking care of these patients. The hospitalized heart failure in all the hospitals, 4,000 hospitals across the United States alone. Why is it important to get this distinction right? That we're not talking about acute kidney injury often when somebody comes in with acute heart failure.
I think it is extremely important, and I think it's extremely important to teach our colleagues not to use AKI and worsening renal function as if they were interchangeable terms. Because as far as our own patients and the healthcare system is concerned, this lead to a tremendous amount of damage. So what has been happening over the years is that a patient with acute heart failure comes into the hospital and is very congested, and the creatinine rises a little bit while the patient is receiving diuretics. And the knee-jerk reaction is to not only reduce decongestive therapies, but at times even stopping life-saving medications that are the pillars of our GDMT. So, even if you talk from a monetary standpoint, you may gain a little by calling more patients as having AKI, but you get punished because the patients that are sent home with ineffective decongestion are not only likely to have worse outcomes, but also are the most likely to return to the hospital and return within 30 days. So in an editorial that I wrote a few years ago for JACC, the title was "Creatinine, Not the Troponin of the Kidney," because as cardiologists, we know that any presence of troponin does indicate injury to the myocardium, but an elevation of serum creatinine can simply be a hemodynamic effect of decongestion and not denote injury at all.
That's a terrific point, and one we've got to get out to, all healthcare leaders and hospitalists who care for these patients. So more of this message is going to be critical to disseminate. Dr. Fiuzat, I wanted to ask you to follow up on Maria Rosa's comments about the abandonment of GDMT and how detrimental that is. You helped develop the Heart Failure Collaboratory GDMT score. If people were abandoning GDMT early on in a hospitalization, what damage? Let's describe in more detail what damage that could be, and how do you think that really does alter the course of these patients?
Yeah, I think Dr. Costanzo laid this out nicely in terms of the clinical impact. The origination of this discussion, as well as the score, really was to guide clinical trials. And so we developed this in the context of, developing let's say, an acute heart failure in particular drug, and not reporting this or stopping the treatment as an SAE in the course, the short course of being treated with a novel therapy, so that it doesn't impact development of these new therapies in the acute heart failure setting. And that really has been the origination of the entire effort, was around acute heart failure development, drug development particularly, or even devices, and this allowable or permissible hypercreatinemia, I think is what we're terming it now. But I think it's brilliant because this really is something that can impact the clinical trial itself and dropouts or discontinuation of therapy in that setting.
Oh, it's so important that just the words matter. I mean, I think that's one of the fundamental themes of this podcast. The words of permissive hypercreatinemia could have so much more influence on people saying, oh, it's okay. It's okay
Mhm.
to allow the creatinine or see the creatinine elevate in this setting. Jason, you look through all these trials, and I looked at, table 3 and table 4, and it's just a marathon of work to get all those trials. What did you see as the important lesson to be learned from kidney endpoints, renal endpoints in acute decompensated heart failure versus chronic heart failure?
I really do appreciate the time to participate in all of this. I would echo, I think, a lot of the points that people have raised already. Notably that I think there's a lack of speaking a uniform language across trials with respect to either the inclusion criteria, the exclusion criteria, or even the endpoints that were measuring for and using as terms of significant within the trial itself. It makes it difficult, especially I would say at the trainee level, where we do have a tendency, I think, to sometimes speak in shorthand, where we sometimes take what the bottom line data is and say that something is associated with acute kidney injury and think that we're all speaking the same language, but in reality, we're not. And I think it makes it difficult to compare apples to apples instead of apples to oranges between trials, especially when we're not taking the time that is really necessary to take a deep dive into the trials like we all wish that we could. I think when we take a look at sometimes just the end results of things and think that we're comparing like to like, we're really not. And I think that that means that we sometimes miss really what should be the take-home message.
A really good point. So much heterogeneity in the work we've done. That the hope of this work is that we get more communication before the trial begins in standardization and utilization of definitions. Anu, you led the good work that we put in here about developing consensus, which was really hard with this group because, I mean, when you got somebody like Steve, nephrology, I can't get him to agree on anything. And you were able to do that and highlight a couple, 2 or 3 of the points where you thought we had the strongest consensus for definitions, terminations, evaluations, and where we really did not have consensus. That's future work is required.
Yeah, absolutely. And I just want to say, it sounds like you work with JCF, Dr. O'Connor, and saying that words matter so much. So I'm loving to hear that. No, but in all seriousness, I think this is one of the aspects that was, yes, most challenging, but also most rewarding. And so what we did was um, establish what we labeled as levels of consensus, right? And so this is not meant to be levels of evidence, right? Not at all, but really how many of us agreed essentially upon a recommendation for the most part. And we did this we tried to standardize it in the way that we as much as possible. But one thing I think we've already touched on is the fact that we should move away from using the term acute kidney injury, especially in the context of heart failure clinical trial design, really with a preference being given to the term worsening kidney function. We all recognize that intrinsic kidney injury is challenging to define because there's no specific biomarker to really signify its presence, just like Maria Rosa said. But I think moving away from acute kidney injury is step number 1 or consensus number 1, and with the preference to using worsening kidney function. The other thing that I really appreciated, and I think this came from our nephrology colleagues, was that we really need urinary assessments to further characterize worsening kidney function. So what are some of those components? What do these look like? So a urinalysis, so a dipstick for proteinuria, a urine albumin to creatinine ratio, because its presence can suggest glomerular disease. And Steve, you can correct me if any of this sounds wrong, because you've taught me so much in this space. And then, it may be that we consider microscopy of spun urine. So I think getting a urinary assessment to further characterize worsening kidney function is important. And I think another thing is that how do you denote worsening kidney function? It comes back to that critical question. I think we all submit that while not perfect, it can be ascertained by an increase in serum creatinine or cystatin C or a decrease in EGFR. However, it has to be contextualized. I think that was one of the things that I got the most out of, is what is the context in which we are describing this situation, and what is the timing at which point it is assessed. I think those are some of the key take homes, in addition to the fact that we've talked so much about permissive hypercreatinemia. Interestingly enough, the level of consensus, if you will, was not at that highest A point that we kind of used to label it, but yet everyone recognized the challenges, and agreed upon the fact that acute kidney injury should be avoided.
Terrific. And as we work on 2.0 of this effort, we hope that some of those Bs on consensus will move to As. Muthu,
if I can
Yeah.
add one lesson also that I've learned from my nephrology colleagues during this endeavor is that in addition to contextualizing the changes in renal function, we need to give them a temporal dimension. And
Yes.
that, there is no consensus about the exact time when you can declare AKI being present, but certainly transient increases in serum creatinine that last only 2 or 3 days or less than 7 days cannot be called AKI. You need a temporal dimension to define the presence of AKI, and that was a great learning point for me.
I think dimension is the key word there, because in the universe we have 4 dimensions, three in space and 1 in time for the 4th dimension, and temporal here being the 4th. And as bringing it back to Anu's point, is we were operating solely in 1 dimension, creatinine rise or not. How simplistic and real Neanderthalic in 2025 to only be looking at creatinine in the setting of a very complex syndrome, right? Where we know from the beginning in the pathophysiology, both congestion itself and fine, if you get to the point of overdiuresis and intravascular volume depletion, both can cause decrements in kidney function and raise the creatinine or cystatin C. So contextualizing that, and then as Anu's pointing out, it's much more. We have much more than just creatinine or functional markers. We now comes in the other dimensions: glomerular injury, albuminuria, proteinuria, tubular injury. We have the markers. We can easily look for renal tubular cells or casts with microscopy. We all have these set up in the hospital when we perform consults. So now you're triangulating function, glomerular, tubular injury, tubular function, tubular health, along with that time dimension. So it's about time we're getting into those 4 dimensions, and we can even add more now with either other markers and using AI, et cetera. Who knows where that takes us? But I think we're catching up with the modern era by putting our hats on and recognizing how complex this whole pathophysiology and syndrome is.
I mean, it's just amazing how exciting it is to talk about words and markers. And I mean, this is a really fun group to be thinking about this. I want to get back to Muthu, though. You've led a lot of trials looking at drugs that influence chronic renal function, and are looking at EGFR slopes, and you're looking at efficacy and safety. Could you describe, in the chronic heart failure space, is EGFR slope a validated surrogate for clinical adverse outcomes such as end-stage renal disease, hemodialysis, renal death?
No, thank you, Chris. And until now, we've been discussing the kidney function changes in the safety column, but increasingly we're really in a wonderful era of heart failure therapeutics in which we have systemically acting drugs, ones that we know alter biology of not only the heart, but also other organs. And so the demonstration of the effects, the long-term effects of these therapies on kidney function and kidney function trajectories is critically important. And patients, too, think not only in the short term about their kidneys, but also about the long-term prognosis. And we have been so used to borrowing kidney function change definitions from our nephrology colleagues. And eGFR slope, or basically the averaged decline in eGFR over time, has been a common surrogate endpoint that has been validated in kidney outcomes trials. And so for instance, an average individual who's older in age has a predictable decline in kidney function, let's say a mil per minute per year. And they can then use what therapies in people with advanced kidney disease that might be quite pronounced. That decline might be on the order of 3 mils per minute per year or greater. And so what do therapies actually do to changing that trajectory has been the great focus of kidney outcomes trials. In heart failure, however, this paper really nicely outlines the number of challenges for adopting that validated surrogate. And unfortunately, we don't yet have sufficient evidence that eGFR slope, those early changes in eGFR, are quite applicable to a heart failure population. And there are a number of challenges, including interval hospitalizations that introduce complexity in the measurement, that the average decline is actually quite slow in most patients with heart failure. That's actually comparable to an aging population. And furthermore, the number of patients that actually reach clinically relevant endpoints like dialysis and transplantation are actually few on a short-term horizon. And so because of that, we might need to think more broadly about how to actually define clinically relevant kidney function changes in the long term specific to a heart failure population.
Really
Can I add
important
one thing?
concepts.
Oh,
Yeah, please, Steve.
And just one other complexity to consider is that many of the pillars of GDMT, SGLT2 inhibitors, aldosterone antagonists or MRAs, steroidal and non-steroidal, and Entresto with the ARB, all when acutely applied, all can generally cause a reduction in intraglomerular pressures due to their effects on either afferent or efferent arteriolar tone. And often these patients get a reduction in eGFR from those medications. Again, a form of chronic permissive hypercreatinemia, and something you have to consider when you're looking at slopes post-initiation and treating of these patients, and you have the problems with acute slope and chronic slopes, and the combination of those drugs again. So again, calling out for the need for other assessments, other dimensions of kidney health and kidney function or integrity over time because of the effects of these medications on GFR in the chronic phase.
And I think, again, it is incredibly important to stop thinking in silos. One example is that we considered the albumin to creatinine ratio in the urine as an exclusively kidney measure. It's not. It turns out that that ratio is also a predictor of prognosis in heart failure, independent of the patient's kidney function. So the two worlds are really begin to converge in more ways than one.
No, it's we're going to have to continue to repeat these themes and speak this language over and over. Maria Rosa, you've done a lot of work in the device area. A lot, and just recently we're at the THT meeting in Boston. A lot of novel devices coming out, and the device developers are very interested in trying to, with some of these devices, influence kidney function They want to improve worsening kidney function, and they're asking, can they use kidney function markers as an endpoint for efficacy in these acute decompensated heart failure trials? And we've struggled with that, obviously, on the drug side. What can you say about what's your advice to the device developers regarding short-term efficacy markers of kidney function?
In fact, I was on a couple panels that discussed that very issue. And just like in the for medical treatment, my recommendation to them is not to be solely interested in the acute changes, but to determine if the improvements that they obtain during that particular hospitalization are long lasting and predict a slower recurrence of congestion, for example. Many of the devices that were discussed, yes, they produce some important hemodynamic improvements as they are being applied, but do those improvements are long lasting and predict long-term greater responsiveness to diuretics, less congestion, and so on?
No, I think we've got to be harmonized, I think, on all sides of the table of what the therapeutic intervention is. And I think that's going to be extremely important. Well, let's go around the room and just wrap things up. What one point do you want to articulate to this broad audience, the millions of viewers on Spotify, on Apple Music, who are watching this podcast today? And I'll start with Steve.
I think contextualization and triangulation are the keys here. And, not all creatinine rises are created equal. These are complex patients. A lot is going on. And yeah, A plus B does not equal C in heart failure. A creatinine rise does not mean decreased diuresis or decreased decongestive options. There's so much more that can be going on. So just use the art of medicine to put this together, and hopefully the trials come together on some harmonization here so that we can have better data analyzed in the next few years to come up with some good consensus definitions.
Fantastic. Dr. Fiuzat?
Well, I'm glad to go first because I thought a lot of good stuff would be taken. But for one thing, we learned that nephrologists are much easier to work with and get consensus with than other heart failure physicians. But also, I think the term permissive hypercreatinemia in your mind, particularly in the context of clinical trials and not stopping some of these investigative therapies.
Great message. Jason?
I would say the two things would be that collaboration is key. At the end of the day, it's one patient, and we can't operate in silos of our different organ systems. We got to talk to each other and speak the same language. And on that, our words matter.
That's perfect. And we didn't tell him to say that from the collaboratory, that collaboration matters. Muthu?
No, my take home is that, in nephrology, we have validated surrogates for kidney disease progression. We have therapies that have been specifically approved by regulators like the US FDA specifically to slow kidney disease progression. In heart failure, there hasn't been a therapy, whether drug or device, approved to actually slow long-term kidney function decline or kidney disease progression. But I don't think that should tell sponsors or clinical trialists to shy away from measuring these, from including them as key endpoints. We have therapies that now have the potential to even improve kidney function, and the actual language, the identification of what is a meaningful change in kidney function in response to these therapies I think we're very close to actually identifying that. And so this consensus statement, I think, brings us that much closer.
Terrific point. Maria Rosa?
So Muthu said something extremely important, and I would like to bring that back. The fact that the renal function in heart failure patients changes very slowly, and we cannot continue to do heart failure trials with hard kidney outcomes, because these trials would take 15, 20 years. So my wish is that we have more discussion to the FDA and see if we can engage them in some type of consensus to use endpoints such as the decline in EGFR and the urine albumin to creatinine ratio. Because in the heart failure trials, we cannot afford the length required to achieve a meaningful number of renal outcomes.
Very good. And Anu, the last word on this wonderful project.
Yeah, no, thank you so much. I just want to reiterate my gratitude for being a part of this endeavor. And it's also such a pleasure to work with our nephrology colleagues. I think Jason said it really nicely. I'm so proud of him as one of our trainees. I think we cannot operate in silos. Increasingly, we are seeing in our field, and I think it's such an exciting time for our field, that we are recognizing the importance of systemic, like whole body health, by virtue of emphasizing cardio-kidney metabolic health. And we, in some ways, over the past several decades, have moved into our individual silos. We're becoming increasingly subspecialized. And now we're being forced to kind of go back to our roots, if you will, and recognize how everything is connected. Heart failure is a systemic disease process and a clinical syndrome that affects the entire body, head to toe. And so we will be putting ourselves at a disadvantage if we do not reach out across the aisle, if you will, and work with our colleagues in other subspecialties to allow for the best possible outcomes. And the starting point there is for us to speak the same language. So I think that this has been such a labor of love, but also a really important first step in establishing a starting point for speaking the same language. And hopefully we'll only build upon that to allow for progress in clinical trials and better outcomes for our patients.
Very well stated. And my wish is that each of you take the upcoming week and get weekend and get some rest. And on Monday, we start 2.0. We know the information and knowledge changes so fast today, and what we've learned today is evolving so quickly that by the time we get finished on 2.0, we'll be working on 3.0. So this is, as you said, a labor of love, but a very important contribution to the field. I want to thank this team. I want to thank your leadership, Anu and Maria Rosa, and all the members of this podcast today, as the importance of disseminating this information, this terminology, this language, this consistency, as Jason said, collaboration in words. So thank you very much today. And this is the HFC Heart of the Matter, and we will continue this communication going forward. Thank you.